Good afternoon. My name is Nelson Lee, the Interim Director of the Institute for Pandemics. Welcome to the Institute's keynote lecture titled Something in the Air. This is the first of an inaugural lecture series of our Institute, which goal is to advance science surrounding pandemic readiness, resilience, and recovery. Today's lecture will focus on the readiness theme and features Professor Kimberly Prather from the University of California, San Diego, and an international roundtable, Professor Trish Greenhalgh, Primary Care Health Services, University of Oxford, Professor Sarah Carr, Architecture and Urban Environments, Northeastern University, Dr. Victor Leung, Vancouver's Providence Healthcare, and Matthew Oliver, expert in engineering and geoscience in Alberta, who will be introduced individually by our chair, Professor David Fishman, in a moment. COVID-19 is undoubtedly the worst pandemic of our time. Not only has it caused excessive deaths and hospitalizations, which overwhelmed our healthcare system, it reveals the many challenges to our public health responses and deficiencies in communication. Further, it has resulted in large-scale socioeconomic disruptions and exacerbated health inequities. The Institute for Pandemics was established within the Dalai Lama School of Public Health in 2020 with the support from Canada's Flora Miller Foundation. It is the first academic unit in Canada focusing on pandemic public health research and education and positions as a focal point for national and global partnership. It integrates the wide range of expertise within the school, and with the emphasis of an interdisciplinary approach, we are working with experts across U of T in many faculties to address the complex, multidimensional challenges of pandemics. Our institute has three interconnected, cross-cutting themes, namely pandemic readiness, to prevent pandemic emergence, accurately forecast its course, and limit transmission through the understanding of transmission mechanisms, which is the focus of this lecture. Resilience, to build a health system that generates rapid, data-driven responses and effectively communicates. And recovery, to mitigate pandemic's broad negative impacts, ensuring equitable health access and outcomes and socioeconomic recovery for all. That is, to build back better and fairer. The lectures of other themes will be announced very soon. Without further ado, I will pass on to Professor David Fishman, lead of Pandemic Readiness, to chair the lecture. Please note that following the keynote, there will be a panelist discussion and Q&A time. Please use the Q&A function of this platform and not the chat function to submit your questions. And recording of this section will be posted in our website in coming days. David?
Thank you so much, Nelson. And I'll start off, just before I get to the intros, I'll start off by thanking the Flora Miller Foundation for endowing the Institute for Pandemics with a tremendously generous gift. We wouldn't be coming to you without that. And thank Nelson for his amazing leadership over the last number of months since he's taken over as our director. It's really been neat to see the Institute go from sort of a twinkle in the eye to a real entity. And I think we're seeing that start to manifest today. I'm going to introduce, I have referred to this panel as the group of people I would most want to sit down with and have a beer with and talk about what on earth has happened with aerosol and the pandemic over the last 18 months. I will hold off on introducing the roundtable until after Dr. Prather's keynote address, but we will have very fulsome discussion. We have a number of questions, including questions submitted by the audience prior to this event, and you can also type in additional questions in the Q&A, although we had over 200 questions submitted by the audience, so we're not going to get to everyone's questions. Without further ado, and I'm going to keep it short because there's a lot to say about Professor Prather, who's emerged as, I think, something of a hero over the last year or two, an expert on aerosols and on how communicable disease moves in the atmosphere, who's brought her very considerable knowledge of science to the public and has really been a brave communicator of what science actually tells us about how communicable diseases spread. She's educated a lot of people, yours truly included, in the face of often unreasonable, nasty, and frankly ridiculous criticism that she's weathered on social media. I'm not known for brevity, but I do want to squeeze this in. We didn't plan this, but our event today is coming within a few days of our Chief Public Health Officer in Canada basically having acknowledged that COVID is a dominant airborne disease. It hangs in the air like smoke. It infects via inhalation, and today Public Health Agency of Canada has very quietly changed their guidance to say that we should all be using high quality medical masks and respirators. That's a big difference in a week. So to turn this over to Dr. Prather and not waste her time, she's a distinguished chair in atmospheric chemistry and distinguished professor at Scripps Institution of Oceanography in the Department of Chemistry and Biochemistry at the University of California, San Diego. And without further ado, I'll turn it over to Professor Prather.
Thank you for that introduction, and thank you for the honor of giving this lecture or the keynote today. I really, it's a big honor to be here, and I've thought hard about sort of what to present. I've in exchanges with David, and so what I've decided to do is do something a little different today, in that, I guess you could retitle this keynote sort of, how did an atmospheric chemist get involved in 2 years of science nearly 2 years of science communication during a deadly global pandemic? Because it's been, as David alluded to, a pretty wild ride. But, through, I would say overall, it's been an interesting ride, and I think it's kind of what I want to bring today is sort of at the very beginning. I just want to highlight what I call my day job. I did have a full-time day job. I do have a full-time day job before all this started, and just to give you my perspective of, I don't know how else to say it, but quite how I've been a bit baffled by how it has been so hard to accept the fact that aerosols are a major way of transporting or transmitting this virus. And so what I want to do is just sort of start with, a little bit about aerosols. And this is the figure that, plays in my mind. This is what I study. I study aerosols mostly outdoors. It's shifting now more to indoors, but I have spent my career, flying around the world on ships and airplanes and looking at aerosols and how they move around. And so these are aerosols. They move much further than 6 feet. And so I would say that was kind of the bait that got me pulled in, was the question, people would literally and still say, do they go further than 6 feet, this magical 6 feet? And so, my research and where I come from and my perspective is understanding this transmission around the globe. The viruses don't necessarily have to be, transmitted by a human to get from one continent to another. They can actually be emitted on one side of the globe and make it all the way around. And so I have a very major interest in understanding this, largely from the standpoint of how their aerosols are impacting climate. They seed clouds, they affect precipitation. And so I come at it, again, sort of from the big picture perspective, but what I hope to get across today is we need to be thinking about this big picture perspective as we move forward and our climate is changing. There is an intimate link between climate change and infectious disease that I will highlight. And I'm going to do this right up front, and then I will shift into sort of the standard or the story about COVID is airborne. So this was a big part of my research, was looking at, flying through clouds. I've built instruments that can sample aerosols in real time and understand basically aerosol seed clouds. They affect, as I say, flooding and drought. They affect, sort of a lot of things to do with climate. And so this is me on a plane guiding the pilots through clouds to try and understand how aerosols are affecting precipitation processes in California. And so one of the biggest discoveries, maybe the biggest discovery of my career, is this, which is we were flying through these clouds trying to understand how California air pollution, which also gives you aerosols, how that was potentially reducing the amount of snowfall that we have in the Sierra Nevadas, which is like the storage bank for our water supply in California. And it just kept going down and down and down and down. And what we found was that on days where dust and biological aerosols that came from over 10,000 miles away, all the way from Africa, so a little further than 6 feet, how these were having a profound effect on the amount of precipitation falling in the Sierras. So it wasn't our local air pollution that was affecting things. It was actually this connectedness that I mentioned. And it was actually the microbes, the viruses and the bacteria that we discovered in the clouds that were having this huge effect. And so, there's a big question about where do these bacteria and viruses, where do they come from? We know they're in the air, but we don't know that much about them. And so sort of around this time, we established a center that I direct. It's a National Science Foundation Center for Aerosol Impacts on Chemistry of the Environment, or CASE. And this has been my day job for the last 12 years at this point. It's a Center for Chemical Innovation. It's a 10-year, well, it's 13 years with sort of the preamble. And so it's, $40 million to look at this question of how aerosols are influencing our climate. And it's an amazing team. It has grown and grown and grown. And I'm honored to be the director of this center. But there's I just want to point out, there is a huge team involved in the work that I will describe. So basically, I spent 20 years building instruments and measuring the real atmosphere and trying to understand things. And we weren't getting where I wanted to be as fast as I wanted to get there. So one of the things I realized is the atmosphere is really complex. And if you really want to understand something like the ocean, which is actually pretty darn important, it covers nearly 3/4 of the planet, then you need to somehow be able to separate the natural, the ocean, from the humans. That's the dream, right? So we proposed to that NSF that if they gave us the money, that we would figure out how to move the full complexity, the biology, the physical oceanography, the full system into the lab, where we could now just study how these microbes, how the ocean is actually influencing our planet. There's a pretty strong belief, a lot of times you've heard of the Gaia hypothesis, that microbes are trying their best to sort of keep our planet in check and trying to help us, but they're changing. The oceans are changing, everything's changing. And so, how can we sort of understand this one big lever that we've quite honestly just not paid enough attention to compared to things like forests or terrestrial sources, which are easier to study, but this ocean is actually very, very important. So if you think about the ocean, people just were treating it as salt. All the climate models just say it's salt. And the truth is there's a lot of biology. It's a forest underwater. And so there's, hundreds of millions of viruses and bacteria, phytoplankton, all signs of life, lots of life, right? And it's playing a significant role in our climate. So what we did was we basically have this wave channel that had been at Scripps for a very long time. We added lights to it. We can move, we have piped in seawater. This is the richness of the biology. And so what we started doing was we started just inducing phytoplankton blooms to see how, as the ocean changes, as the biology of the ocean changes, the atmospheric composition changes, and then the climate changes. And you can see that we can feed it nutrients, simulating what happens in the real world. And then all of a sudden, these colored dots are all the richness of the biology that I mentioned. And so our fundamental question was, when this happens, which viruses and bacteria become airborne? And what is their role in our climate? And as I will discuss today, how are they affecting human health? We know virtually nothing about how the oceans are influencing our health. So this just shows a bigger shot of the wave channel. It's got breaking waves, real seawater. These are all the measurements where we're measuring, the DNA, the RNA, and the air and the water, and really trying to make the connection of the biology in the water to the biology in the air, and trying to understand this human microbe tug of war, if you will. And so the other thing we've done working with oceanographers, this has been the best thing I've ever done in terms of sort of interdisciplinary research. I've become a real believer because we work with oceanographers to understand this transfer process. It turns out, and this is one of the things I've talked about, and I think people, I mentioned, bubble bursting happens on the surface of your lungs. That is how aerosols are getting out of you when you talk. And I'll get more to this. It also happens on the surface of the ocean. And so that is what is releasing this enriched amount of aerosols that contain biological material, including viruses, into our atmosphere. So it's kind of funny to think about the surface of the ocean and the richness of the biology there and the bubble bursting being similar to your lungs, but that is what we think. And so we can look at this enrichment process. We can look at bubble bursting in smaller systems, smaller scale systems. we're adding things like Vibrio cholera and other types of known waterborne pathogens to really go after this question of, are they really only waterborne, or is there a larger airborne component? And so again, there's lots of ways to burst your bubbles incorrectly and make bubbles that don't look like the real breaking waves. But we've come up with ways to do it where we actually can simulate this transfer process and really start to understand which microbes are making it into the air. So in doing this, one of the things we've learned, I should say, we weren't the first people to think about the ocean as being a source of viruses. This is a paper published in 1977, a lot of work done by Duncan Blanchard looking at this issue. So if you think about the ocean, it's water, right? But these microbes are hydrophobic. They don't like water. So they sit on the surface of the ocean. When bubbles go in, when waves crash, those bubbles rise and scavenge all this hydrophobic material and then pop, and you get this huge enrichment of the microbes in the air. And here's some images that we've collected. This is a bacterium in a little droplet. This is a phage invading a bacterium. These are what we actually sample in the air. And so one thing that we're really interested in, and I will get to this quickly, is, we know in coastal regions that there's lots of sort of human viruses that are ending up in these regions, and it's getting to be more and more of an issue, as I will describe. But the big question we went after right off the bat was, does everything just make it into the air, or do all viruses and all bacteria just get transferred? And the answer is no. And this is really complex, and I acknowledge that, but I just want to point out the red are things that are enriched in the air relative to the water, and the lighter bluish purple colors are things that remain more in the water. And you can see there's a huge amount of enrichment. We're now trying to understand that. We're trying to figure out if there's some sort of method to the madness of climate, of why certain things get out and certain things don't. So these are bacteria on the top, and these are viruses on the bottom. And that was our very first study in 2018. And this is where I first had the light bulb go on to start thinking about airborne viruses. So it's taking this to the next step, and I want to get through this quickly so I can get to the meat of the discussion of SARS-CoV-2. I have a really major interest, and this was going on before the pandemic hit, on these microbes and what is getting into the ocean, and in turn, what is getting into the atmosphere. Again, getting back to this question of how does the ocean influence health? And so one thing that's happening in San Diego is there's this massive amount, millions of gallons of raw sewage get dumped into the ocean. There's a whole background to this. It's an environmental disaster, to be honest. And so we've been studying this region, trying to understand what makes it into the air. But the key point here is that this is going to be happening more and more. And it doesn't just happen in San Diego. It happens in all coastal regions. And that when you get, now we're starting to see far more flooding. And we're basically getting less storms, but when we have storms, they're more intense. What does that mean? It means that there's a lot more of this stuff, human influenced microbes, that are going to be pumped into the ocean over time, and pollutants just in general. So this is just going to become a bigger issue, and it has become a really big issue. So we're looking at that. So one of the things we did, just to kind of see if we were crazy or not, is, people think that when this sewage, when the sewage goes in the ocean, they were really worried about the surfers and the swimmers. Don't go in the water. But nobody tells you, what about the air? Should you be holding your breath? A lot of people think, ocean's massive. You dump a bunch of sewage in there, it's just going to, it's going to just go out and be diluted, and, you'll never see it. But what we did with the oceanographers is they released this dye that simulated this. This is the estuary that's going into the ocean. And we studied whether we actually could see this dye in the air, and if we did, how far it would actually go. And so, the answer is we saw a lot of the dye in the atmosphere, and it went everywhere. So once any pathogen or pollutant or toxic species gets in the air, a lot more people are exposed to a lot more of it than they would be if it just remained in the water. I want to make that point. So, basically, when this happened, we started thinking about, okay, the sewage. What else is in the sewage? And when the pandemic hit, SARS-2 is in the sewage. So we started looking for SARS in the ocean, in the estuary, and in the air. The good news is so far, we have not detected it in the air. We have detected it in the ocean, and we have detected it in the river. But again, like, we haven't looked at whether it's infectious or not. We just know it's there. There's a lot of work to be done on this. But one of the interesting things is, you know, we've actually started to make this connection of whether the water, you know, gets in the air and what ocean conditions make a difference. And so this just shows 2 days, 1 day where it hugged the coast. The idea is if it stays in the surf zone, that is the launching point. That is the way to get a lot of this pollution up into the air. If it goes out to sea, then you won't see it in the air. All right, so can we link, you know, this is for the future. I just want to set the stage. Maybe we can talk about this later. And this is the last little piece I want to mention. Can we link atmospheric transport patterns, ocean transport patterns of viruses and bacteria with disease? And so the best example of this is actually a work that is led by one of my colleagues, Jane Burns, here, the Kawasaki Disease Research Center. And I just want to quickly plant this seed. This is Japan. These are air circulation patterns in Kawasaki disease cases in Japan, San Diego, and Hawaii. And what you see is when the wind transport patterns are set up right, you can actually see this huge link where people in all of these different areas between continents get much higher incidence of Kawasaki disease. The other little point I want to make is they didn't know if Kawasaki disease had a biological origin, if it could be viral, until this year. With masks and the pandemic, Kawasaki disease dropped to all-time levels, low levels, and now it's coming back now that we're taking away a lot of the measures. So it's a hint, it's just a hint. But then, you know, this is just one virus. What about other viruses? What about other pathogens? What about other bacteria? You know, what are the health effects? The ocean is massive. And again, there's a lot more of this over the oceans than we ever imagined. So, and how is this going to change? Again, I know you have this great institute thinking about these issues, pandemics, what leads to pandemics. This one has been large, SARS-2, as we'll talk about, has been largely indoor. But what about, you know, outdoors? We know SARS-1 was largely sewage and transport in the air outdoors. So we have to think about this. This virus seems to not really like sunlight. It also probably doesn't like salt water too much. But as we move forward, you know, the ocean is getting warmer. There's more toxic blooms. There's just so many things that are changing in our sort of natural environment. There's so many, we're going to basically be changing the things that we're exposed to over time. And so this is just planting a seed for further discussion. Okay. So now you understand sort of, hopefully, my background and my day job and why how I got pulled into this crazy pandemic. But basically, I made some statement in March of 2020 that, of course, aerosols travel much further than 6 feet. And as they say, the rest is sort of history. I'm going to give a very brief discussion of this, but just I'm going to try and set the stage for the roundtable that we're going to have. So I don't think I have to dwell on this too much, and I almost dropped the early. The public messaging on this pandemic has been terrible at best. You know, in February, WHO said it was airborne, then within minutes took it back. There's a lot of discussion about that. This tweet still exists on Twitter. You know, there's just been so much misinformation, and it's really unfortunate because people have lost trust. I don't blame them. They don't know who to trust. And so partly because of this, a number of us, aerosol scientists, Team Airborne, we all gathered together, we all met. This is one of the good sides of Twitter. We all met and we started working together to try and help people that were completely lost and scared and worried about how to protect them and their families. And so that is what we've been doing for the last couple of years through many different platforms to try and sort of shift this focus from cleaning surfaces to getting people to just realize it's in the air. It's that simple of a message. And so, you know, this was March of 2020. They say it isn't airborne, but it's definitely borne by air. This is still, people are still going out of their way to avoid the use of this crazy word, airborne. So my initial contribution was seeing all this craziness. I sort of looked at all the pieces of the puzzle. People were spreading it that didn't know they were sick. They weren't coughing, they weren't sneezing, but somehow it spread around the world. So it had to be in the air, right? And so aerosols, just the strict definition, is solid or liquid suspended in air. I wrote this is a perspective. it's set the record for downloads in Science. It's over 1.6 million times it's been downloaded. All it said was basically, since we don't know who's sick, so everybody needs to wear masks to reduce the spread. And I believe to this day that if we had believed this and cleaned our indoor air, I wouldn't be talking right now. We would have gotten out of it. Places that took it seriously of it being in the air fared far better than those that kept trying to go back to washing hands. And don't get me wrong, it's important to wash your hands, but it's not, it just was this, nobody knew what to do, what to focus on. And that has been a serious, serious problem. I also was helped organize and was part of this airborne transmission. This is the National Academy of Sciences, right? August of 2020. Every speaker, every expert just got up and said, it's in the air. It was like consensus, why is there such confusion? That was the topic, this long ago. And so, it's been, out there that it's in the air. This is Lindsay Marr and myself. We've gone on, I don't know how many shows and tried to get the word out. The number of us have, Jose Jimenez, just a bunch of people. We constantly, I feel like a broken record, honestly, but we keep saying it's airborne. So this is the view right now. What has led to this pandemic? And it's aerosol transmission, airborne transmission. Aerosols are in the air. So I think just honestly calling it airborne transmission is fine with me. And so this is a figure that Lindsay made, but the concept is people talk and they release droplets, a few droplets, not many, 1,000 times more aerosols. The droplets drop. That's key. That's where that 6-foot craziness came from. But the aerosols float like cigarette smoke, as David mentioned at the beginning. And so the aerosols not only float, but in poorly ventilated spaces, they build up. And they build up just like being in the room with a cigarette smoker. And we all know what that's like. And so that will basically lead, if we inhale it, that leads to exposure. So the number one way is short range aerosol inhalation, which has been sort of convoluted in a crazy way that if it's close, it must be droplets. Not true. And long range aerosol inhalation, AKA by medical terms, this is airborne. And so the bottom line is, this is the picture that we have with Delta. It's become even more obvious. Masks that worked before, such as medical masks, stopped working, don't work nearly as well because it's aerosols, it's not droplets, and I'll talk more about that. So I won't go through all the evidence. I think, most people that are listening have seen all this. I've talked about it. I mean, this is a slide taken from a debate that I did with David, with John Conley. And so, basically, what it has taken to sort of prove it's airborne is just unbelievable, but it is a paradigm shift. And so, I guess it's in that regard, it's been relatively quick, but not quick enough is what I would say. And so basically we know that aerosols are produced. People talk, they're produced. People yell, more are produced. People sing, a lot are produced. People exert themselves through exercise, even more are produced. We know that. They're short range in aerosol inhalation. Then they said, well, how do you know it's in the air? So they sampled it from the air. Then how do you know it's infectious? It's been cultured from air, I think 5 times right now. Measles has never been cultured from the air, yet it's called airborne. And so, basically all the pieces are there. And I couldn't even, this used to list all the publications. I can't anymore. All evidence that we have points at aerosol transmission leading to this pandemic. So, how do we know it's not droplets? I don't know. We keep asking, many of us have asked, could you please provide droplet proof that it's in the droplets? It's enriched. All the measurements where they looked at the size, it's always in the smallest sizes, which are the ones that go the deepest in your lungs, which affects the severity of the disease. So it's really, really important. But the other thing that's happened that has really driven this pandemic is that, they estimate between 10 and 20% of the people that have been infected lead to 80 to maybe 90% of the infections. And so what are the commonalities? Indoors, low ventilation, not using masks very well, being in for a long time, and people that are yelling and talking, as I say, back to poor. But there's been now thousands of documented super spreader events. They happen in gyms, choirs. This is a restaurant. This is the infamous restaurant issue where there was, air got trapped at this end and all the people down at this end got sick. This is a great one. This is one where a chorist went in, was infected, didn't know it, was looking away from the people behind that got infected. So I love to say that droplets don't make U-turns. And so it had to be aerosols in this case. And so this is another case where they put bins, 4 bins in, sort of between these ferrets, and basically, they got infected, and they were able to blow the air. Aerosols do bends, aerosols follow air, droplets would just splat and get stuck in the tube. And so again, there's just everything points at aerosols. Now, I say that, I can't say that droplets never do. We don't say that they never affect things, or surfaces never affect things, but the majority of the spread. I mean, there's no way that, you think about a super spreader event where 80% of the people at that event got sick. They didn't get it by licking the same salad fork, right? We know that. And the one thing that's in common is that we share the same air indoors. So this is a paper that was written, Trish Greenhalgh, who's going to be on the panel, led this, and it was a paper in Lancet that really, I think, had a big impact. But the point of this paper was, this is the 10, now there's more pieces of evidence, but you can't pick these apart. Like, they all go together perfectly, and they all, the super spreader, the long range transmission, the fact that people spread it when they don't have symptoms. The big one is it's much higher, happens much more indoors than outdoors, and ventilation has a huge effect. That wouldn't affect droplets. So I won't go through this. If you haven't seen this paper, it's in the Lancet, and it really, I think, lays it out in a very short, succinct way how we know for a fact that aerosols are playing a major role in the spread of this disease. So one thing that's come up a bunch, and I want to see where I am. Okay, one thing that's come up a bunch is, droplet versus aerosols. And I'm hearing this even today. I was reading this even today. Isn't this just semantics? Don't we all just need to agree? Can't we just come up with some sort of agreement on a word? And it's just terminology. It doesn't really matter. It does matter. It matters because we're not giving the proper protection to the people who need it, especially healthcare workers that are getting sick and dying. And so that's just not okay. And so, does there really need to be a consensus on terminology? I think this is something we'll talk about on the panel, I hope. But if we agree, yes, that would be a good thing. Like, all fields need to agree. It would be nice to reduce the confusion. Then if we say yes, then just say it's in the air. Just say COVID is airborne, or SARS-2 is airborne. And that's the end of it. The public understands. The medical community would now have to provide the proper PPE. People would be provided with the proper protection, and we could end this thing. So, as I say, if you make me pick, I would just go with airborne. If you want to stick with aerosols, that's okay too. But either way, it's in the air, and we inhale it, and that's how we get infected. Just to drive home, because I still see this, that basically, a lot of people will still, talk about which masks people wear for different procedures in the medical community. This is work done on looking at the number of aerosols produced by a certain activity compared to just normal breathing, where not as many come out. And what you see is that, normal respiratory activities of talking, exercise, shouting, and coughing lead to massive amounts of aerosols compared to some examples of the different aerosol generating procedures, in which you can see that numbers, you can't even hardly see them, right? Here's the conundrum, and this has to get fixed. In this case, healthcare workers are given droplet precautions, and in this case, they're given airborne precautions. It's backwards. If you're, giving airborne precautions over here, you should be giving it over here. Droplet precautions do not protect you against inhaling aerosols. The reverse is true, though. If you use aerosol or airborne precautions, it will protect you against droplets. So where did the precautionary principle go during this pandemic? In SARS-1, we'll talk about this towards the end. They implemented it eventually, and it showed that it worked. It just doesn't, this is one of the biggest questions that I personally have. So one thing I'll say is, as mentioned, this is a paradigm shift. We published a review in Science recently that talks about just all airborne, many respiratory viruses are airborne. And it feels funny to even sort of say that, like that shouldn't be a surprise. Respiratory viruses go in your lungs, they're inhaled in your lungs, and they're in the air. Like that, I don't understand honestly why that is such a shock versus droplets that are dropping and have to like, randomly hit somewhere. The probability, just based on probability alone, but again, the measurements have shown a lot too. So I just want to mention, I think we're at the point where we need to look back, and if we're thinking about future pandemics and thinking of just respiratory disease in general, we need to really be thinking hard about airborne transmission. So once we acknowledge it, I was told, don't say the word airborne because you'll scare people. I don't think anybody's ever told me that I scared them by saying the word airborne. I think it's a fixable problem. We can shift to cleaning the air. CDC is now fully acknowledged. They've said, transfer from surfaces is not that as important. Basically this was finally in April of 2021, but we're excited to finally see that, there's evidence, but they still will go, there's still sort of the confusing message. If you look through all the web pages and all the documents, they will still kind of say, it sounds like aerosols and fomites are about the same in terms of how we protect against them. So why is it important? As I mentioned, I think the public deserves to understand, so we can know that we just need to clean the air. People are still shocked when I say this to them. We can help the public understand why, not just do it, not just ventilation is great, as the WHO has been saying, but why? We have to give credit to the general public as understanding these things, and why the distance matters, and why we have to think about how to reduce risk. Really importantly, and something that I feel passionately about, is how to protect healthcare and frontline workers. What has happened to them is just not right. And so, we need to really think about ways, this is, over 100 years ago, we knew people had to be outside. And, somehow we forgot, we can use sensors, we can be smart, yeah, they're invisible, but we can actually, there's ways we can decide whether the air is safe indoors. So, basically, I just want to make the point, it needs to be out there. It needs to be a clear message, and we can get through it. So this is actually a paper that goes into thinking about, once we acknowledge it's in the air, what are the riskiest activities based on occupancy, based on, all the things we talked about. Basically, the riskiest situations are indoors, small crowded spaces where people aren't wearing masks, restaurants, bars, elevators, bathrooms. One key thing that a lot of people don't realize is that if you go into a room where an infected person has been, that aerosol can hover for hours, infectious aerosol can hover for hours. So what a lot of people do is, if they don't see anybody present, they just take off their mask. The people don't have to be there. The virus can still be there and you can inhale it. So that's true in cars. Again, confined spaces are really problematic. So we have to think about improving masks, both in terms of sort of fit and function. The choices have really gotten good, go from masks also up all the way up to respirators. As again, I think this will come out in the conversation. I just want to mention this here. They've gotten a lot more comfortable making sure that, those medical masks are not enough without a brace, but you can make them enough by a simple, little adjustment. And so I just want to make that point. Again, I think this will be discussed more. The last thing I want to sort of touch on is just the successes we've had in being able to, I think a lot of people, they call us, like the people pushing against reopening, because we say masks are important. Masks are what allow us to reopen and stay open. If people, anybody pushing back against masks, that is leading to us having to keep this yo-yo going. Basically, to reopen schools, I pushed hard for cleaning the air and wearing masks. And this was a school district with over 100,000 kids. Kids came to school infected from home, and there was no clusters, there was no outbreaks. Like it was, it worked. You just clean the air. So, requiring masks, better ventilation, simple things like opening doors and windows, bringing in a higher proportion of outdoor air through your HVAC system, making sure your filters were good in your system. Probably the biggest safety net, in my view, is standalone HEPA filtration, or these Corsi Rosenthal boxes, which I'll talk about in a second. All you need is just filtration. You just want the virus to go in the box. Just filter it out in the box instead of your lungs. It's that simple. don't buy ionizers, don't buy plasmas, don't spray chemicals into the air. These are all things that just cost more money and potentially make worse air to breathe. And so just, a simple filter is all you really need. Lunch at schools was by far the riskiest time, still is. Best to eat outdoors if you can. I understand not every place has the climate of San Diego, so this has been a challenge for a lot of places, and just sort of keeping smaller cohorts and being aware. When we opened last spring when we still had, I guess, it was before Delta. The fall I was a little nervous, to be honest with you. We had a huge school event webinar that we talked about how to do this well. But we now have the vaccines are becoming more helpful. The air has been cleaned, and now there's more and more testing that's being done. All of these things are needed. This is what we did. We basically put particle counters to look for aerosols. We put CO2 sensors to look for ventilation. So these look at, total aerosols in the air. This looks at the amount, you'd like the number to be low, so it's like clean, and we can talk more about this. But there's no downside to doing this. This is long overdue. We have ignored indoor air quality, poor indoor air quality, especially in schools, for far too long. This is the silver lining of this pandemic. If we can improve indoor air quality, we can increase attendance, attention, test scores. There's nothing but benefits. We can reduce the amount of flu that we've just come to accept as a way of life in the winter. There's just so many positives. So we have monitoring going on, to sort of see what's there. The school has been great about putting out information to help the parents understand. That's what good schools should be doing. Unfortunately, they aren't all doing this. This was one of the things I feel sort of that makes me smile. These are the Corsi-Rosenthal boxes. And again, we can talk more about these. But one thing people told me very high up, that we would never be able to clean the air before school started because it would cost too much. These you can build we built these for about $70. These are ones we put at UC San Diego for $70, $100 maybe. Some places it's harder to get the components, but this was a grassroots effort. They're built. This is one person in Hawaii. All over the world, people were able to buy these filters and put them in their classrooms, so that if the ventilation wasn't great, or if kids had their masks on a little crooked, this is that extra layer of protection. We know layered protection is important. So this is a beautiful effort where people just took control and said, we are not helpless, as Jim Rosenthal often says, of the Corsi-Rosenthal boxes. So yeah, this has just been an amazing thing to see people come together. The Clean Air Crew, I should do a call out if you want information. This is just an incredible site with a ton of information, especially related to schools. The one thing I have to mention is there's also some pushback on sort of whether filters work. Again, that's why I kind of started out saying, I'm an aerosol scientist. How could reducing the amount of aerosol in the air that you inhale not reduce the amount of infection is my question. But people say that. So this is just, people have gone and measured it. They put the filters around a classroom and show in the red, when you have filters, that, the amount of aerosols, total aerosols, go down. But the virus is in that same size range. And so that's also going down. It's going into the filtration system again, rather than your lungs. It takes about, basically the aerosol concentration can go down by 90% in less than 30 minutes. And so again, I think this has been, anecdotally, I think this has been a huge player in the lack of outbreaks in many indoor locations. So schools just have to be given clearer guidance. There's so much confusion. It's a bad situation. But the do's I've already mentioned: getting enough air changes, using proper masks. The don'ts: no ionizers, no plasmas, no gadgets, no plexiglass barriers, which tend to block your ability to ventilate properly. They can actually concentrate the aerosols in your breathing zone. Less surface cleaning. Still important to wipe down surfaces, but there's just far too much money and time that was going to that, and the air was being completely ignored. I still walk into businesses and there's hand sanitizer and there's nothing that's been done to the air. It's still the majority, which is, again, because of the confusion. So UCSD, we did, these are tests and vending machines. They're free, PCR tests. We have masks, outdoor classes, we did sewage surveillance. We created a safe bubble. It was far safer. The number of cases at UC San Diego with the kids going back to school was far lower than in the community. And again, it took a lot of buy-in from the students as well. So where are we? And I will just wrap up with this. You would think, I would think, we would hope that, given how obvious it is that it's in the air, that we wouldn't be looking at this plot. And this is from yesterday, but this is the world situation. And it's just wave after wave after wave. And I keep saying, we keep saying, how many times do we have to prove to ourselves and tackle this? So this is cases by region. They have the US, I think US and Canada is together. You can see Europe is taking off, exploding right now. This is starting to tick back up. We're going into winter. We're going into holidays. This plot makes me sad because I honestly don't think it has to be this way, as I've mentioned before. And I'm a little bit at a loss. The good news, as David mentioned, is, Canada, your neck of the woods has admitted that aerosols are really important. The basically Theresa Tam and Twitter, where many announcements go out, is the evidence of aerosols is important. This was on November 12th. And even the WHO, and this is from the chief scientist at WHO. This is a tweet, again, everything happens in Twitter world. We at WHO have recognized airborne transmission for a long time. So some of us it's a mixed bag. We're happy that they're saying this now, but for a long time, you can look at the guidance. This gets back to protection. October 1st, they're still recommending a medical mask, which blocks droplets, not aerosols. For healthcare workers, they're still saying if you're involved in AGPs, you should think about a respirator. Still saying that. And there's very low certainty evidence that basically, basically respirators can also be used instead of medical masks in all settings, but this is the low certainty. To me, it's the highest certainty. So there's still confusing messages, unfortunately. The last thing I'll say, and I hope this will come up in the discussion, I just want to, if you haven't, I'm sure, again, in Canada has a certain recollection of SARS-1, and, it was airborne. And why would SARS-2, why would people not accept it sooner? It was fear of panic and political blame. Back then, 2003. This commission report, if you haven't read it, is amazing. Justice Archie Campbell was involved, and this whole debate about droplet versus aerosol protection happened there. One city did droplet protection, one city did aerosol protection, and guess which one had the least cases? Proven already. And so, what's the difference? Toronto went with droplets, Vancouver went with aerosols. And, they implemented the precautionary principle. And that was the major conclusion of this report, is how important the precautionary principle is. Over 100 years ago, people knew that it was important to be outdoors and to abstain from staying in closed spaces, poor ventilation. This is 1918. Keep open the windows, ventilate frequently, be outside, have fresh air. All these things were known over 100 years ago, and yet we still are stuck where we are. So I think I will end there because I think I'm probably at my time. And I really what I wanted to do today was to just I wanted to set the stage for this discussion. And again, I wanted to give a perspective of an aerosol scientist. Many of us have had this background, and it's been, lack of a better term, a wild ride. I'm glad that we've been able to help people as much as we have, but we're still not in the place that we need to be. The last few days, this week, I have more hope because now people are starting to say, it's airborne, it's in the air. So, we're getting there, but we still have a ways to go. But, I try to always be an optimist. So anyway, I look forward to the discussion, and I hope that I've set the stage for a good discussion. Thank you.
You sure have. That was fantastic. Thank you so much, Kim.
Thank you.
I'm going to lead off with a couple of questions directly to you because we have a few minutes. And then at the hour, I think we'll flip over to the roundtable. That was amazing. That was a tour de force. So I'll start off with now to your point about schools. We sort of have the case of the dog that didn't bark here in Toronto, where our school boards have actually put HEPA in the classrooms. Ontario has been very slow to explode this fall. What we're seeing is explosion in other jurisdictions in Ontario. Still not seeing that in Toronto, really Greater Toronto. One of the major arguments against overhauling ventilation, and we've done some of that, is that it's too expensive, right? This is infrastructure. It costs a lot. How do you respond to that assertion?
Costs a lot compared to being stuck in a pandemic for 2 years. How much is that costing the world, right? Somebody did a calculation, it's just for the US, as Rich Corsi did a calculation of how much it would cost to put like just one of these crazy Corsi boxes in every classroom in the United States. And it was like $1 billion. We keep running through these $1 trillion infrastructures and the money's going. Schools are getting billions of dollars, tens of billions of dollars. Where's that going? So we're already putting out the money, not every place is, but what I like about the boxes, is that everyone has access, right? So one of the things we've helped families, multi-generational families, which we know it transmits in households, right? So I can't say anyone, but there's been a lot of donations. We're now getting many donations of filters from companies that are really excited by helping, this is a way to stop the spread. That's kind of the patch, I would say, right? Although I will always run a HEPA filter in my house after this, right? Or in my office. I think everybody's thinking about things differently. But yeah, to your point, I don't think it's that expensive to basically, if you look at the offset in health costs and kids missing school and being shut down, having to stay home, right? There's no comparison in my view. And I think there are ways, yeah, there's expensive ways, but I would argue the money is out there. It has been.
We have a colleague here at University of Toronto, Dr. Jeff Siegel, in the Faculty of Engineering, who's also been pointing out for a while that overhauling ventilation in schools actually pays dividends in other ways too. He likes to tell us about the database that's there for improved test scores in kids who learn in well-ventilated environments.
Absolutely.
Another question, I'd like to circle back to your absolutely amazing pre-pandemic life and focus.
It's still there, I hope.
It's still there. It's here in Canada, you're on the same coast. We've just dealt with sort of this atmospheric river phenomenon in British Columbia that's caused some devastating flooding, and Victor will be able to give us the boots on the ground view of that. But climate change is really starting to show its hand. It's not abstract anymore. What do we know about the direct health effects of microbes from the ocean, and how is climate change going to affect that over time, and how does aerosol tie into that?
Yeah, I mean, we know very little about the health effects of the ocean. I think if you look, I think I have people sometimes tell me when I go to the talk, they'll say I've just ruined their Sunday morning walks on the beach where they're inhaling the fresh ocean air. Now I've ruined it for those poor people. I mean, it's not always like that, but you should, like in places where, there's outfall, sewage outfall, all they're looking at is fecal counts. So it doesn't even have to be just raw sewage. It can be any sewage once it goes in the ocean. They're not looking at the number of viruses. They're not looking at the bacteria, right? So I think, just the way we've been treating the ocean as a dump, no pun intended, it's catching up with us. It's changing the microbe colonies along the coast, which is changing air quality, everywhere. No one even thinks about this stuff. So I think, to your point about climate, I think my gut feeling on the biggest issue for climate is this flooding effect. You washing all this extra stuff into the ocean. And again, it hurts the ocean, right? It's hurting that whole food chain, if you will. But if it is getting into what's getting in the air and how's that affecting humans, we haven't even begun to scratch the surface of how it's influencing. And that's for my last sort of hurrah of my last 10 years of my career, however long I've got, that is the focus that I'm going to be very strongly taking.
Thank you so much for that.
Mm-hmm. Mm-hmm.
I'm going to take a moment to introduce our panel, and Kim, if you could keep your camera on, I'll ask the other folks on the round table to turn their cameras on too, and I'll do a quick round of introductions. So I'll go from the top of my screen to the bottom of my screen, just in the order that people have appeared. So Professor Trish Greenhall is Professor of Primary Care Health Sciences and a Fellow of Green Templeton College at University of Oxford. She studied medical, social, and political sciences at Cambridge and clinical medicine at Oxford before training first as a diabetologist and later as an academic general practitioner. She has a doctorate in diabetes care and an MBA in higher education management. And I know not in her bio, but she became a fellow of the National Academy of Medicine this year in the US, which is unusual for a non-US person. Sarah Jensen Carr is Assistant Professor of Architecture and Program Director for the Master of Design in Sustainable Urban Environments at Northeastern University. Her work and research on connections between urban landscape, human health, and social equity has been recognized by the Graham Foundation, the Mellon Foundation, and the National Science Foundation, and has been published in Preventive Medicine, the Avery Review, Places Journal, Hawaii Journal of Medicine and Public Health. And she also has, I believe, a new book, which is Topography of Disease.
Topography of Wellness, yeah.
Topography of Wellness, sorry, there you go. There's my
Yeah.
physician view of the world, flip it around, which looks fantastic and is on Amazon. Dr. Victor Leung is an infectious disease physician, medical microbiologist, and the medical director of infection prevention and control and physician lead for antimicrobial stewardship at Providence Healthcare in Vancouver. And Victor has been a leading Canadian voice for following the science in infection control during the current pandemic. And last but most certainly not least is Matthew Oliver, who is the Deputy Registrar and Chief Regulatory Officer of the Association of Professional Engineers and Geoscientists of Alberta, regulating engineering and geoscience in Alberta for some 72,000 engineers. And he has background investigating catastrophes, so he'll be able to comment perhaps on how things could have gone better. Welcome to you all. Thank you so much for joining us. If it's all right, I don't know if any of you sort of saw questions in the Q&A that jumped out and that you're champing at the bit to answer. If you did, please raise your hand and go ahead. And if not, I'm happy to go around and offer questions. We had a bit of discussion beforehand about these for each of you. So I'm going to seize chair's prerogative then. And ask Sarah. So Kim showed us a picture of people 100 years ago, sort of understanding the importance of outdoor air and fresh air for prevention of disease. You've written a book about how interventions, how our understanding of disease has shaped our urban environments. How have interventions for airborne transmission and miasma fears shaped urban environments in the past?
Well, thank you, David, for the honor of the first question on this incredible roundtable. And it's just I'm just an architect and an urban designer, so it's incredible to be with all of you that are working with this on a daily basis and fighting for this recognizance. So I just wanted to put that out there. It's an incredible honor. So thank you for including me, as incongruous as it may be. But I loved, I loved Kim's presentation from beginning to end. Thank you so much for sharing your knowledge. And I also sort of sparked to this idea that, she kept showing this idea that, over 100 years ago, there was actually quite a bit of environmental change that was affected around the fear of airborne disease. Now, of course, although cholera and yellow fever were proven to be passed in water at first, there was still this idea and this fear of miasma that's been in place since sort of Hippocrates 400 BC. That said, a lot of the changes that came as a result of this and a misunderstanding of disease, but again, it's sort of like multi-pronged effort to combat disease in the urban environment. And so what we saw in the wake of the cholera and yellow fever in the UK, in the United States, in Canada was, first of all, the installation of huge sanitation systems, of putting wastewater underground, which was not just to pass out the water, but also to trap what people thought were miasmic gases underground as well. I also love that Kim showed that, has talked about it's been a practice for a long time to kind of put waste out into the ocean. And I think the historian Martin Molosi said, a lot of people have subscribed to this idea that the solution to pollution is dilution. And of course, we are getting that. It's blowing back at us now. So it's something we need to keep in mind as well. That said, these disease fears over 100 years ago, not only did they affect sort of a total overhaul of street infrastructure, of waste infrastructure, but also housing and thinking about how the most vulnerable people were housed in a city. The insistence on building codes that allowed for windows and sunlight and fresh air. And then, of course, what I think is most relevant to today is even after the cholera and yellow fever epidemics had passed, and we were still dealing with respiratory illnesses, such as tuberculosis and the Spanish flu pandemic, then there is where we really see still a lot of effective environmental change towards fighting these diseases. And so we see a trend in Europe and in the United States in the tuberculosis epidemic of open air schools, right? And insisting that windows be open. And actually, I ran a studio at Massachusetts Institute of Technology this past year where we looked at schools in Cambridge, and we were looking at their age and seeing like how could they be retrofitted for fresh air ventilation. What was amazing was all the schools that were built sort of pre-1940s had the potential to have windows open. And of course, they had window units sort of stuck in them instead, so they couldn't open the windows anymore. We've sort of bypassed this idea of fresh air ventilation in favor of thermal comfort instead. But when we were doing this project, people also told us, well, there's no way you could do an outdoor classroom in Massachusetts. What about the winter? And we would bring up these historical examples from a very famous open air school in Providence, Rhode Island in the tuberculosis epidemic, where you saw fresh air ventilation, but they provided the students with blankets to sit in. They heated soapstones to put at their feet. They gave the children hot soup every day. And this is a movement that was specifically looking at vulnerable populations, and that's who was treated first. And so they identified children in poor districts in Providence and actually invited them to be in the school. And then, of course, there's the design of sanitaria, which originated in Europe, where you had hospitals that had sleeping porches outside, right? So patients could be wheeled out. The porches were built to actually accommodate a hospital bed, so there could be fresh air ventilation. I think in a lot of the developing countries, we've sort of lost that ethos in thinking about passive ventilation. That said, there are developing countries such as Haiti and Rwanda that don't have the resources we do, and they are looking at passive ventilation in fresh air ventilation in healthcare as well. But for whatever reason, I think in a lot of developed countries, we've sort of been concentrating on the medical and are not looking at how built environments can be supportive and mitigating in the face of pandemics. And I think what's most promising, if we think about the kinds of interventions that we can make in the built environment, that is increased access to green space, increased access to walkable environments, and to encourage active transportation instead of riding in cars or being on the highway. And then, of course, thinking about fresh air ventilation in our buildings, that's not just pandemic resilient, but it is climate resilient. It is better for mental health, and it is better for overall health as well.
Thank you so much for that. I mean, one of the really interesting things, it seems, there's a lot of stuff that seems not that smart in retrospect, but thinking back to our parks and outdoor recreation spaces getting roped off early on in the pandemic. And perhaps that was a manifestation of precautionary principle early on. But you know, those have emerged as real oases where people can stay fit and protect their mental health and engage with others, you know, much more safely. But of course, we have equity issues around where the green space is in our cities as well. I want to if any of the roundtable want to respond, I don't want to be overly directive here. So I'll throw it out to the group if anyone has a response or additional comment. But otherwise, I'm going to turn to Matt next and ask, you know, your professional hat or helmet is very much an engineering one. But I know, and you've sort of pointed this out on social media, that your heritage is Métis, and that there are different ways of understanding and approaching this pandemic viewed through an Indigenous lens than perhaps through the sort of the dominant, I guess I'm going to call it settler lens in Canada. So let me ask you that as a double-barreled question. What aspects of an engineering approach could have changed the pandemic response? And how would an Indigenous approach have dealt with the challenge of the pandemic differently? So sorry, those are two very big barrels, but that's a double-barreled question for you.
And I have 3 hours to respond, did you say, David?
You have 3 hours, exactly.
Thanks for the chance to be a part of this panel. And I feel very similar to Sarah. Architects and engineers are often partners in design work. So I'm feeling very much out of place. And thanks to the other panelists for being the kind of citizen scientists that I've always aspired to be in my career. It's yeah, I know it's been costly, but it's been wonderful to learn from all of you. So on the engineering side, I actually found in late 2020, I had to start blocking infectious disease professionals on Twitter because I was starting to get more and more angry, and it wasn't healthy. And one of the things I realized was that what was happening was absolutely offensive to what engineering's ethos is. So just a couple comments on that. You know, engineering, we're rooted in the natural sciences applied in practical ways. So we understand physics and chemistry. It's the reason why we don't use randomized controlled trials in engineering, because we can model things. We don't need to RCT whether or not reinforced concrete is going to hold a building up, because we've learned from modeling and our understanding of properties of materials. Engineering is fundamentally interdisciplinary in approach. It's not just architects and engineers, but if you're on an engineering project, you're working with dozens of other professionals who are far more expert than you in their specialties. And these are things that I really saw violated earlier on. I have to also say that, you know, my perspective is there is no more evidence-based practice than engineering, because the concrete doesn't care what you think about it. If it's inadequately designed, the building or the bridge is going to fall down. And one of the reasons we're so evidence-based is because our first ethic, and it's encoded in law in Canada, is that we have to protect the public above all else, including sacrificing ourselves professionally if it gets to that point. I think the other thing is that's interesting about the engineering approach is that we're really a profession that's defined by failure. Harry Petrowski wrote this in a book called To Engineer as Human, where he talks about how our profession is really driven by the goal of eliminating failure. And to do that, we become experts in failure, which means causality is a core part of what we're trained in. And so many failures of good causal analysis, they're legion over the last 2 years, contrary to the evidence. So it makes engineers, I think, very attentive to detecting failure modes that we've seen in prior engineering events. Just one example, you know, the Challenger disaster happened when I was an undergrad, really defined my career in many ways. Experts who identified the risks who were overruled for other reasons by people in positions of authority. So there's big echoes of that. Like Dr. John Snow's story, there's no real new failure modes under the sun, and we've seen them all repeated in the pandemic. So on the Indigenous side, at the danger of sounding pan-Indigenous, because there's so many different things when you bring up that term, but some broad themes. So I mentioned citizen science. I think that's a really core concept in Indigenous engineering and science, that the reason we're concerned about what the public and what we do is because we're part of a web of relations. We're part of a community, which includes all the people that use our designs. And one of the other things that came up early in my response to reading some of the IPAC interactions was very visceral. And it struck me that I was reacting to a process that's colonial in nature. Basically an authority assisting they know best, even contrary to all the evidence, and that results in violence and harm being done to other people. It's actually the core facet of what colonial systems look like. And I think, all of the panelists to varying degrees have exposed themselves to forms of that violence by being outspoken advocates for what everyone on the panel knows the evidence has been saying to us since 1918 or earlier. And that's a basic feature of systems. So one of the things I realized is a lot of the stuff we've been facing really isn't about evidence. It's really not about facts anymore. It's about power and control, which is another facet of that colonial experience. Professor Greenhalgh's paper on the philosophy of science was really interesting, talking about the emphasis on objectivity. And this is the Indigenous link in. I think I'd go even further as an Indigenous applied science, because the whole idea of suggesting that an observed process is unbiased or independent from the observer is actually really foreign to the whole cosmology of Indigenous peoples, because to say that you can somehow parse apart ontology and epistemology, it just doesn't work, because as I observe the experiment, I am in fact enmeshed in the experiment, like ontologically entrained, maybe to use an aerodynamics term. You're always drawn into it. And that's because, for us, the defining characteristic is this web of relations, which means when you're conducting an experiment, you're in relationship with all the aspects of the experiment, including the things that Western science would consider inanimate aspects of it. There's a Canadian prof, Sean Wilson, talks about Indigenous experiments or Indigenous research as being ceremony. And that really defines that relational aspect, because relations forms our reality. So when you're doing Indigenous science and engineering, it's based in relationship and community and mutual responsibility, mutual obligation. I'm not a dispassionate person doing something that's going to result in a paper that's being published. If we had been doing that from the start, this very power flat open space with all the voices having room to speak would have led to a really different public health response, because there wouldn't have been the sort of power moves that we've been seeing repeatedly to suppress valid evidence and valid research, which is still going on. The Alberta response to Dr. Tam's changed position is, we published that in November 2020. We don't need to relook at our position, which is, pretty predictable. Yeah, so there's the engineering and the Indigenous response summarized in less than 3 hours.
Thank you for that. That's fascinating. I'm going to turn now to, I think the natural segue is to Trish Greenhalgh. It's your very wise papers have now been sort of highlighted. Let me ask you, you're very much involved in sort of the world of clinical evidence. What have we learned about the concept of evidence in clinical medicine from failures to follow science on aerosol during the pandemic?
Again,
sorry.
Sorry, you've got another half of your question. Keep going, David.
No, I think that's plenty for starters.
I think we've learned that Hugh Davis was right when he said that evidence is what powerful people say it is. I am staggered at the difference between conferences or seminars like this one, where most of the questions are saying, why the hell aren't people recognizing this? And medical conferences where people are still asking how many angels you can get on the head of a pin. Have we got the definitions right? Is there really any evidence of aerosol spreads? And as Kim showed brilliantly in her lecture, the WHO is still classifying the evidence around airborne transmission of this virus as low quality, as limited. And yet amongst most of the people who are putting questions out on this seminar, it's clear, it's barn door obvious. It is absolutely the only thing that will explain the data. So why does that happen? It's partly because people went into this pandemic assuming that respiratory infections are spread by droplets. People thought that was the way influenza spreads. Actually, there's been plenty of evidence against that, but in the mindset of so many doctors, this was respiratory infections spread by droplets, coughs and sneezes, all that kind of thing, hence handkerchiefs, hence sneezing into your elbow, all those kind of things. So they started with that mindset. Second reason, it's very hard to change once you've already made up your mind. Psychologically, it's difficult to backtrack. It's embarrassing, but it's also cognitively more effort than sticking to your guns. Thirdly, politically, it's a lot easier to put the emphasis on droplet precautions because these are things mostly that individuals can do, whereas, as we've heard from the engineers, airborne precautions require major changes that employers have to do, that public providers like those of schools and hospitals have to do, that governments have to do. Why else? Lots of reasons. I think the other thing is scientific capital. And I put something in the chat just now, a paper that I wrote with Mustafa Ozbiljan and Damien Konstantiopoulos, who's a Canadian social scientist, about the power base of infection prevention and control people. They're the ones who sit on the committees. They're the ones who decide whether the evidence presented in front of them is acceptable. And I have attended WHO committees where I have tried to put on the table evidence from aerosol scientists, and I've been told by those committee members, this is crap, this is rubbish, this is flaky, all those terms of abuse. And of course, if they're the ones who control the mute button and they're the ones who control who gets invited, then that's where the evidence gets, that's the kind of evidence that gets accepted. So we are in a very, very sinister position here. That's probably enough for one question.
Could I just ask a follow-on question? You've written about narratives. How does the idea of a narrative kind of interdigitate with the idea of, you know, what is the evidence? How does storytelling drive the pandemic response?
Well, about nearly 20 years ago, about 17 years ago, I developed a technique for reviewing evidence across many different disciplines called meta-narrative review. And a meta-narrative is a fancy name for a research tradition. It comes from the work of Thomas Kuhn. And the idea is that scientists in any tradition tell each other a story about what the key research questions are and how they are going to be answered. And when I supervise my PhD students, I try to inculcate them into the unfolding story of research in my tradition. The problem is that it's not a problem, it's actually an opportunity that different groups of scientists have very different meta-narratives, different stories about how we should be looking at this particular topic. And I was fascinated when Kim was presenting her stuff, because I always wanted to know why an oceanographer ended up looking at the transmission of SARS-CoV-2. And now I know, because what she was doing in that early bit of a talk was explaining the oceanographer's meta-narrative about how fluids move. And how we study and how we address questions about how fluids move. So the narrative includes a set of concepts, it includes a set of theories, and it includes expectations around what methods and instruments get used. And I'm now quoting directly from Kuhn's Structure of Scientific Revolutions. So I think we could use the word paradigm. We could say that the WHO and the infection control people are stuck in a paradigm that is not helping them, a paradigm that is closing their eyes to evidence that could move us forward in the pandemic. So I think the narrative is absolutely key. Understanding that people are locked in the wrong meta-narrative is probably, quite a good way of looking at this.
So that then it becomes, I'll turn to Victor next, because it becomes quite difficult to explain Victor. So Victor Leung has been absolutely remarkable in that he's, you are a practicing infection control physician, director of antibiotic stewardship, and you've managed to keep up with the science. I would imagine we don't have to get into this in terms of what the cost has been for you personally or professionally. I knowing that I am not in that world, and I've faced a lot of nastiness from, I am an infectious disease physician, and certainly faced a fair bit of nastiness from within the ID world. You're in infection control. So first off, kudos in terms of your courage and integrity. Second off, kudos in terms of the interview you gave to CBC in Vancouver last week, which was just a beautiful articulation of why this shift is so important. And now I'll turn to some questions and ask you, specifically, you're in this decision-making role. What have you done in your hospital IPAC program to address airborne transmission of SARS-CoV-2? And I believe you're both hospital and long-term care based. And then the second part is, what challenges have you encountered in implementing interventions to address airborne spread?
First of all, yeah, thank you for this opportunity to be on this wonderful panel. I've learned so much from members on the panel, but also scientists who have published a lot on this. And I can say that as an infectious disease physician, infection control physician, this, in the field that I'm in with antimicrobial stewardship as well, I've enjoyed it because of its ability to collaborate with multiple disciplines. And most of it in the beginning was with physicians and nursing staff, people who work within healthcare, so that we can understand the problems that they see on a day-to-day basis and try to have dialogue and understand the problem. What happened early on is it wasn't easy, because based on our training and from exams, for example, what we hear from mentors and how we learn about infectious diseases, this emphasis on understanding the foundations of transmission, especially with airborne transmission and versus this framework of droplet transmission, was not well explained to many of us as we go through our education. And it wasn't until the pandemic and we started to have outbreaks in long-term care that I think it was a coincidence that I was able to stumble upon this literature. We were seeing in our long-term care facilities at the beginning ongoing transmission, despite our best efforts to follow all the guidelines that were we were told needed to be followed and needed to have consistent messaging so that there wouldn't be ideas of miscommunication and different perspectives. So I think what was mentioned earlier about this top-down approach of control, although it has its advantages, also has revealed many problems that we've seen. And so when we started to have these large outbreaks that were uncontrolled, we started to try different things, including testing asymptomatic people very early on. And we found and identified asymptomatic staff. But that didn't fit the narrative. That didn't fit what we were told at the time needed to be done for testing, and that type of testing program was shut down. And so based on things that happened, I was asked to, during this long-term care outbreak, to move back to acute care because of some other priorities that needed to be addressed. But I suspect that part of the move was not for me necessarily to just be back in acute care, but it was partly to remove me from the disagreements in relationship to management of these outbreaks. And Kim talked about the NASM workshop that occurred. And I remember watching that subsequently and learning a lot about this that kind of made me think to read more about this and learn from others. And at the same time, Kim mentioned this reference to salad fork. I found that really funny because I remember during the long-term care outbreak, we were told by infection control colleagues that we worked with that, you know, the reason why you probably aren't controlling this is you haven't looked at the shared food and you need individually wrapped plastic forks, is what we were told. And so subsequently moving back to acute care, seeing a large outbreak as well. And we tried to control this differently with higher measures or different measures that are really targeted towards airborne transmission. And we were told at the time when we wanted to use portable air handling units, HEPA filter units with exhaust to the outside, we needed a few hours to do the same thing on another ward rather than just the COVID ward. And in consultation with public health, we were told that that was not necessary and would be too high risk, that in their experience, ventilation was not going to be an important factor, and it was not approved. So that immediately was a red flag for me and really heightened this kind of discordance in approaches to thinking about how we should be collaboratively working together, because I think we can learn a lot more from people who are experts. And when a public health physician that has no training in engineering is telling me that ventilation is not important, it kind of changes the working relationship a bit. So that is kind of some of the difficulties, and I've tried to overcome those difficulties by just professionally and continuously try to address colleagues and send them articles. I think at one point I was told by a colleague I should stop sending these articles because it's dominating the conversation in this chat group. So others have reached out and said, asked us about what we've done at our hospitals to control outbreaks. And I think that now that there's this opening invitation to share more knowledge, recognizing the modes of transmission. So briefly speaking, in terms of our hospital and our long-term care facilities now, in infection control, we talk about horizontal measures as well as vertical measures. And some of these horizontal measures, of course, like hand hygiene, basic environmental cleaning are important, but we also now focus on horizontal measures like testing every case on admission. That was a bit of a battle because it was counter the narrative of what the guidelines are. So every case is detected, but we also have a very low threshold for using rapid antigen tests in the right setting to test patients and staff, along with our RT-PCR when that's required. The other horizontal measure is that N95s are used, respirators are used for all staff whenever there's an exposure on the unit. So the exposure is assessed, how infectious that person may be, and the context is assessed. And we don't say it for the whole ward at this point when there's exposure in a room, but for everyone managing other patients in that room, N95s are required for all care. And the infectious cases move to the COVID ward. And then we also have measures, horizontal measures on our COVID ward where all staff are wearing respirators. Now, how effective that is will depend on the patients that we see on the ward. I think as mentioned on the chat, many patients who are on hospital wards may no longer be infectious. But when we have hospital-acquired cases or newly admitted cases from long-term care in the community that are still infectious, these measures of N95 respirators are very important as something that the healthcare worker can control. Another horizontal measure on our COVID ward is that very early on, thanks to our facilities engineers, every room was changed in terms of its ventilation and filtration, and that we have negative air handling units with all the windows taken out so that the air handling units takes air in and filters before exhaustion to the outside. So when the doors are closed, it does create a negative pressure to some extent, and also increases the air changes. And in the areas where we have outbreaks, for example, or newly identified clusters, we will immediately have our facility teams place a portable HEPA filter in that shared airspace and do regular testing for the initial 7 days to assess for transmission. Once we've started to do that, we've seen huge gains. Our clusters are much more smaller. Now, of course, vaccination has had an impact for that, but also our ability to control outbreaks now in long-term care have changed. So as a team effort, we rely on our engineers. We use CO2 monitoring to assess various rooms. We check air changes, not just saying that they are designed, that they meet the original design standards, but we have engineers come in to measure inflow, outflow, to calculate air changes and ventilation per person in that room space. So a lot of the work that we've focused on now, whether they be horizontal or vertical measures, really have come up because of our openness in wanting to collaborate with engineers. And we will continue this work, thinking about air quality, collaborating with different groups, trying to understand how we can measure and improve air quality. And one of the things that we've done recently is gone to the UBC Engineering School and pitched to the engineering and Scripps co-op or project teams to try to think about what projects we can collaborate on. And I think that there's, this is opening our minds to the importance of collaboration and infection prevention and control, something that has always been fundamental, but unfortunately has had a narrower focus during the pandemic.
It's interesting. I mean, I sort of feel like this panel is a great illustration of what can happen when you cross disciplinary boundaries, just in terms of the accumulated wisdom that you get when you're not sitting in a silo with other people who think the way you do and went to the same, you know, trained the way you did. I'm going to turn it over. I think unless everybody's got the next 2 weeks booked off, I don't think we're going to be able to tackle all the questions that have accumulated. But I'm going to just throw these out to whoever wants them. There are a lot of questions, so we don't have buzzers. But if you want to, I guess, just put your hand up in reality or virtually. One question that's come up a few times, and I think this is so important, is we have had very sort of proscriptive public health guidance. You know, this situation do this, that situation do that. But really, you know, you can't prescribe for every possible situation a human being finds themselves in. And it seemed to me that one of the things that was so important about Dr. Tam's change of messaging this past week is that it gives people a bit of a mental model so that they can improvise, you know, once they understand the basics of what we're talking about. Do any of you have thoughts on, here, two questions that are sort of the same question. What would a good public education campaign for airborne transmission include? And what have you found to be the most effective way to help lay people understand how to protect themselves? I'm not sure if I'll throw that out to the group if anyone has a thought. Trish?
Well, I'll kick off. I really liked the 3 C's campaign that Japan brought in very early. You know, by middle of March 2020, they were talking about 3 C's: avoid close contact, crowded places, and now I've forgotten what the 3rd C is. Someone quickly tell me. But it was like really simple.
Close and crowded. Yeah.
Close and crowded. Yeah. So it doesn't. I mean, it doesn't cover everything, and it didn't cover all the stuff around ventilation and measuring CO2 levels and all that kind of thing. But even now, you know, you go into a service station, you go into a store, people do not understand the real basics of this. They still have all those sticky things on the floor. You must stay 1.5 meters apart, but they don't say they don't say you mustn't stay in this store for any longer than you have to, you know, all those kind of really simple things. So I think, but the other thing is, if we're going to do a public health campaign, we need a psychologist, we need someone who's an expert in public communication, because although it's wonderful to have all these people on the call, we still need more people from more disciplines to kind of help us design the messages. It's quite a sophisticated science. I'll hand over to someone else who knows more about this than me. Go on, Kim.
I wouldn't say I know more than you, but I've learned a lot from you. So yeah, I mean, I'll just say that I just think keeping it simple is so important. I think that, you know, as I almost I run the experiment. I talk to everyone about the fact that COVID is airborne. People see me coming in the grocery store and I think they run the other way because this crazy lady's going to walk up and talk about it being in the air. And, you know, I mean, it's in the air. COVID is airborne. That's it. To me, like, we've actually talked about whether we should put up buy a billboard in New York City or London or wherever and just say COVID is airborne, you know. It's that simple. I don't think it's that complex. I think it's been made complex. And I think that's where people just have gotten confused and tuned out. But when you tell people it's in the air and you can breathe it, and you tell them to envision cigarette smoke, they get it. I mean, kids get it. 5-year-olds, honestly, with open minds, get it before many 50-year-olds. You know, I mean, it's just, so I just really believe simple messaging is what has been lost. And sometimes I think it's been done on purpose, which is not good. So I'll leave it at that.
I mean, the point's been made in Canada that it's sort of surprising that people struggle with the concept of aerosol in a country where you can see your breath 6 months a year. But here we are. Sorry, Matt, you had your hand up.
I was just going to add to those super comments that one of the things that really troubles me about this is, you know, one of the facets of the era we live in is some fundamental distrust in sources of truth. And the really unfortunate thing about the fact that we have not been communicating, present company accepted, really clearly with the public, who are not uninformed for the most part. They can get the scientific principles if they're being communicated well by someone who understands what's going on and can translate the complexities. Is that we're actually going to fuel I think a wave of anti-science sentiment that's going to come, because, you know, we're going to hear things like, well, you've been telling us messages that they keep changing, and now you're saying we should be wearing better quality masks, but you've said for 18 months we shouldn't. And there were people saying we should wear better quality masks in March 2020. So what's changed? Which is really, I find that one of the really upsetting things about what we're experiencing is that we're probably, to coin an old phrase, shooting ourselves in the foot in some way in terms of what are things going to look like when the next pandemic comes along? And we're trying to do the same messaging again that we were trying to do in SARS in 2003 and have forgotten for this one.
Yeah, I would just add, I think, you know, as the other panelists have said, unfortunately, we've been very caught on our heels by changing guidance, right? And I just, you know, to talk about the American context, what's interesting is actually, you know, before COVID hit, most of the communications team at the CDC was fired. That whole department was cut in the United States. And I think this speaks to how important kind of the science of communication is. And now I'm very interested in this because I'm a visual thinker, right? And design spaces. And I think the issue is more, I think, you know, especially the secondhand smoke analogy, I think is very effective. I think thinking about how long you're in spaces, I change, you know, sort of my protective gear depending on, you know, when I'm in a classroom, I teach a class that's 3 hours long. So I wear a respirator, right? Even though I'm vaccinated, because we're in a classroom for a long time. So there's those changes to make. I think people can understand the concept. The problem is we haven't given people tools to mitigate it, right? We've been asking, everybody is fending for themselves. We're asking elementary school teachers to build their own filtration, right? Or to make decisions based on you know, what happens from day to day. We're not giving people the correct masks even. And so I think it's actually perhaps not the concept that's such an issue, although it is on the higher level, but rather we're not giving people straightforward tools to protect themselves, and we're not changing their environment.
Thank you. I think that's right on. Victor, do you have anything to add? You don't have to, but can I just bounce a question back to Sarah? And this isn't fair because there's so many unasked questions, but this is something that's been on my mind a lot. And I mean, Matt, this may be something you're thinking about as well. So Sarah, you've written a lot about, built environment and the past and how disease has shaped our cities. I mean, I think that this has been enough of a kind of societal earthquake that we'll be seeing the echoes of this for a number of years to come. I know there's a big emphasis in government and a lot of businesses in Toronto right now to get people's bums back into seats because the rent is paid on the office space. But I also think that folks have realized that there's a lot that they can do virtually, and at some point it may not make sense to have such a big office footprint. We also have a lot of building stock in Toronto that went up during the energy crisis, where the idea was seal the heat in, and we don't have to worry about ventilation. I mean, how do you have thoughts on how our buildings and how our cities are going to possibly look different in 10, 15 years as a result of this episode?
I mean, I think, this idea that built environment and actually natural environment, right, as Kim so elegantly showed in her presentation as well, is, we've, because of the sort of like 100 years of a schism between these professions and the medical profession, we've kind of separated out the influence of the environment on health. And so we're in a long process of reconnecting the importance of it. And not to say that the environment can cause or cure disease, but it is a supportive structure, right? I think we are very much in flux. My concern is like almost the entire history of public health, which has like sort of, disintegrated from a period of benign neglect, right? Or in terms of funding and in terms of listening, is that we're not just reactive to COVID, but we are thinking proactively. And I think, unfortunately, what I see now, especially in Boston, Massachusetts, where I live, 80% of the downtown is office space. A lot of those workers have gone remote. And there's been no real discussion about how to proactively face it and how can buildings be reused to possibly provide housing, which is also like a very badly needed resource, right, in our cities. How can we repurpose auto infrastructure and make sure people aren't just driving individually to work instead of taking public transit because they're scared of taking public transit now. And if people are driving individually, that is not good for climate change in the long run as well, right? And so unfortunately, I think we're seeing a place where we're still very reactive and we're not looking at the intersection, especially of pandemics and climate change and health. Because there are strategies that could tackle all three of them. But right now, I think everybody's very much in a wait and see mode. And unfortunately, unlike in, say, earlier eras or progressive eras, where there was a real need to, there was a real push to sort of like take care of the most vulnerable. There's also maybe, I think, an inordinate amount of discussion on sort of like middle class, upper class remote office workers and not frontline workers, right? Not healthcare workers, not people in service industries, and what happens then and how do you keep their environments resilient as well?
That's thank you for that. Sorry, Matt, I wasn't sure if that was a hand.
Yeah, I'd love to hear Matt's take too.
Yeah, just a quick comment. I think one of my hopes out of this is that there's going to be a revolution in building codes to actually address the issue of indoor air quality. I have to say, I advocated and got our workplace to buy a measuring instrument to look at CO2, but also got one that does PM 2.5 and PM10 and volatiles in the air. And we have a really good building, but surprised to see how much particulate matter, fine particulates there are. So it's not just an issue of, infection prevention. It's also an issue of just the whole broad question of quality. So my hope is that when we go into the building code revision cycles, we're going to see this considered. And this isn't just commercial or residential, it includes hospitals. I think there's going to be a revolution in what hospital ventilation looks like. The gap we have right now that Sarah just described is in the built environment, where there is relatively little regulation beyond the authority having jurisdiction over occupancy of the buildings to influence what's happening. And this big gap of And if you're in a Class A commercial building, you probably don't have an issue because the building managers are probably on top of the stuff, ASHRAE stuff anyway, but it's the middle ground of older buildings that maybe aren't as highly maintained or have as high rents. That's a real issue, which is probably a lot of our retail space as well. So what's going to happen in that gap in terms of regulation or enforcing new ventilation standards in that space? Beyond the excellent citizen science we've seen with people with CO2 meters posting pictures on Twitter and saying, hey, I'm at the Senators game in Ottawa and look, the CO2 is 2,500 parts per million, which will force changes on its own.
I'm going to put in a plug for Art Gallery of Ontario, which has apparently, to protect the paintings, indoor air quality that's similar to outdoor air, has CO2 of 500 or 600. I'm going to segue to, and I apologize, there are so many questions. We're not going to get through them all in 15 minutes. But my terrific critical care colleague, Brooks Fallis, is up with a question, which I think is a really good question. Now, Brooks had written an editorial some months ago saying, let's forget about the hospitals. Let's get acknowledgement of aerosol so we can protect essential workers in warehouses and in meat packing plants and so forth. And that went over like a lead balloon, I know, here in Ontario. And I can only imagine that he is as frustrated as I have become. And I know that I have a sense that I want to see error acknowledged. I don't want to see this gaslighting from the WHO that says, oh, we've been saying it's airborne for the last, which, they haven't. But at the same time, I think Brooks's point is an important one. Is it important to have acknowledgement of error? Or if people just change the messaging and start explaining and, you just let that go by and acknowledge that, we are where we are and we need to move forward. How is it important to have acknowledgement of error in order to get off on a new foot, or can we simply get off on a new foot? Curious to know what people think. And by way of context, I know that Joseph Lister, who was a surgical father of antisepsis, Lister in his letters to his dad talked about the importance of making the surgeons he was talking to think it was their own idea, that it came from them and he was just channeling what they said, because he knew that if he challenged them and said, you've been wrong all along, that they'd just be, he'd lose his job. And Ignaz Semmelweis, who was the guy who came up with hand washing to prevent infection in hospitals, did lose his job and ultimately died prematurely. And Semmelweis, famously accused his fellow physicians of being murderers, and it didn't end well for him. So, is it important to get that acknowledgement of error, or is that just going to hold us back? Trish? Yes, Trish, go ahead.
Yeah, I can't quote chapter and verse to you, but without any doubt, the psychologists we can hear you. Without any doubt, the psychologists have demonstrated that people trust sources who admit their mistakes, but they also trust scientific papers that are not oversold to them, and where people acknowledge more than one explanation for the data, that kind of thing. And this is, of course, what we teach our students to do. Before the student's been inculcated in scientific writing, they give everything a really hard sell, like an advertising campaign. And then you say to them, hang on a minute, draw back on that and be a bit more restrained, and people will believe you more. So I think there is a problem with what the WHO is doing. Because people have been putting in the chat, I no longer trust the WHO. That's a really scary thing for people to say, but actually neither do I.
Yeah, they're Kim.
Somebody else was, or you? Yeah, I'll just quickly say, I think it's important. You did. Victor has openly, you both have openly said, I learned, and that's, I think, a really important, I think, you know, I haven't looked at the studies, but I just know who I trust. And, you know, we all are, I don't know, you call it wrong, you know, sometimes it's wrong, sometimes it's, in this case, you know, I don't, you know, the trust part really is bothersome when there's this gaslighting, as you've just, I've learned more about gaslighting. I didn't know what gaslighting was before. And that's made me on shaky ground as well. And so, but I think it's really important, and I try really hard to just embrace those that are going to say it. Like, to me, however you want to say it, you want to admit whatever, you want to jump to the side and start getting it out there and helping, we're all going to work together. I really mean that. To rub it in and beat them up, then they're never gonna. So I always keep waiting for that house of cards to fall, you know, people that are examples like you. And as I say, Victor, you guys, you know, you both went from, you know, but there's still people really holding back, almost like they're afraid lightning's gonna strike, and it doesn't, and it won't. So I just hope that we can get to that point, like, soon.
Oh, Matt.
Just a quick comment. In that paper of Trish's I was talking about later, she uses some really interesting language about orthodoxy, which I've got some background in theology as well. And I have to say that one of the things a lot of these discussions has struck me of is that there's far more religion and doctrine being promoted than science. And I would actually say that humility is a cornerstone of anybody who's practicing in any form of science, because as I heard somebody say, a Canadian scientist say once, science reserves the right to prove itself wrong anew every morning. And you have a hard time doing that if you don't go into it with the humility of my last 3 years of experiments may turn out to be not. It may not be cold fusion after all. It may be something else I'm detecting. So that admission, I think, is key to credibility. If somebody can come out and say, you know, we were actually completely wrong about this, is a far more compelling message for me than somebody who comes out and I think, oh, your communications team has spun this one because we're very concerned about this. We're studying the data, but there's no admission behind it that they gotten the data wrong previously.
Sarah, I wasn't.
Yeah, I just wanted to go back a little bit, and I just wanted to say, you know, it's wonderful to be on this panel. I actually work with a group of faculty across many universities in Boston called a health humanities group, and we talk about the importance of bringing humanities into public health study. And so I loved hearing, you know, Trish's discussion of meta narrative, right, which is so important, and medical narrative, which, you know, is essentially, I think, what I try to do in my research too. And I think this recognizance of power dynamics is so important. And I did, you know, in my previous professional life, I actually used to design healthcare facilities. And so we were often interviewing doctors and nurses. And something we found on a project in New Orleans early on was that we were asking doctors and nurses and technical staff to kind of just, you know, do their day-to-day. And when the doctors were in the room, the nurses and the tech staff would not speak, and they would not tell us sort of like where they went on a daily basis and sort of what their needs were. And they weren't always, you know, synchronous with what the doctors were saying. And so this is not so much about who you trust, but I think, you know, when we're trying to put together these panels and we're bringing across fields to that awareness of humanities training, of power dynamics, and is very important to recognize, as well as Matt also pointed out in his talk.
Victor, did you have a comment?
So looking at it from a hospital culture point of view, I know that speaking with colleagues, when we talk about organization culture and how people feel at work, it's important to have that foundation of expecting full disclosure. We know that no one is coming at this with bad intentions. Everyone's trying to do the right thing. So that part is not difficult to address. We all agree on that everyone's doing the right thing. But I think this aspect of admitting that there were errors made gives us a lot more trust when we have full disclosure. And so we don't need to perseverate on it and keep talking about all the errors indefinitely, but I think it's just a simple acknowledgement that we can't know everything at the time. And for people to change their mind requires different levels of evidence. And I think once we acknowledge that there is this been a misunderstanding or an error, and then we can move on, because that is foundational in having trust in an organization.
I fear we are getting into what they call it overage time now. We're at 2:55 in Toronto, so we've got about 5 minutes, and there are a lot of great questions here. Does anyone want to comment on the issue of equity? This has been a pandemic of inequity as much as anything else, and we've seen that in terms of how risk has been distributed in the population. How do we address the issue of aerosol in an equitable way that empowers people that are most at risk? Does anyone have thoughts on that? That's a tough question. Kim?
Yeah, I mean, I think about this from an indoor air quality perspective that I mentioned a little bit, in that the people that have been breathing the worst air for the longest in an inequitable way are the ones that were hit the hardest, because their respiratory systems were not up to par, a lot of them, because they've been breathing such bad air for so long. So to me, I just focus on we're trying to get particle counters and filtration systems into their, to clean their air, because they are literally, their classrooms are horrible for kids, right? And they grow up with that their whole lives. So I keep saying, I talked to the Biden Equity Task Force, and I made the case that, this is a way to help with equity by making sure, like everyone, but make sure those classrooms are finally clean. We can't control their air at home, but they spend a huge amount of time indoors at school. So we could give them the cleanest air they ever breathe. And that's going to help their lung development, their cognitive development. It's just the benefits will help for a long, long time. And then they won't be as vulnerable when respiratory disease or whatever hits. So I think, as I say, cleaning indoor air would be a big step in that direction.
Could I just seize Chair's prerogative here, because I don't want the thank yous at the end of this to sound like, we don't have televised pharmaceutical commercials in Canada, but we get US television. So there's sort of the rapid fire stuff at the end of the drug commercial where they talk about all the horrible side effects very, very quickly. I don't want our thank yous to sound like that. I do want to just read something out. So Mario Posamai is certainly one of the wisest people I've met during the pandemic. And he has put a comment in the chat, and because I can't get him to say this out loud, or I don't know how to, I'm just going to read it. So this is so Mario is a lawyer who was part of the one of the SARS commissions. He has been a real strong advocate for safety in the workplace, has been arguing that this is an airborne disease, needs to be treated appropriately from the get-go. And what he's written here is, I'd argue that we need public accountability. If someone prevented construction workers from wearing protective gear, wouldn't they be sanctioned? Our public health and IPAC officials have failed month after month to follow the science. You can excuse their positions and actions if they're over a brief period of time and there's an openness to change. But should IPAC professionals who've stubbornly resisted the science be let off the hook after all the damage their actions have caused? Not sure that's good for society and for faith in science. So I think if it's all right with the panel, I'm going to let Mario have the last word. And the next time we do this panel, I will get Mario to be a part of it too. But I'm going to sort of close here. There are some people who need to be thanked for making this event, which I thought was pretty fantastic, a reality. First among them is Obadiah George, who has done the heavy lifting on the IT stuff behind the scenes, and got us all through a dress rehearsal and made sure we all understood this platform. Zanita Hergy, who is really running the administration of Institute for Pandemics now at the University of Toronto, has been very, very key to making this happen. Heidi Singer and Francoise McCanda do communications for the Dowlena School of Public Health. And I believe they'll be coming out with some clips and a media release, as well as working on getting a link to you all so that you can rewatch this and share it. I'm going to circle back again and thank Nelson Lee for his amazing leadership of Institute for Pandemics, and as well as the Vora Miller Foundation for funding. And absolutely not last, I want to thank our keynote speaker, Professor Prather, for a fantastic talk, and our roundtable. You just all shared so much wisdom and so much insight. And there are requests that we share the chat, because and thank you to the audience, because frankly, it's been a very engaged audience, and there's a lot of wisdom in that chat and in the questions as well. And I apologize, we only have 2 hours to do this. It's clearly a much bigger topic. But with that, Nelson, shall I turn it over to you for the final farewell from the director? Or,
well, thank you, David. I believe I don't have anything to add. I'd like to thank everyone for your participation, and it was really a great session. I learned really a lot. Thank you.